Right, a very warm welcome to everybody who's joining us here today on this EPI-WIN webinar. My name is Sarah Hess and I work for the World Health Organization based in Geneva, Switzerland. I'd like to welcome you to this webinar that is going to take a look at the WHO perspective on booster doses in the context of global vaccine supply. We have with us today, and I'm very pleased to welcome her, Dr. Annelies Wilder-Smith, who is the focal point for the SAGE working group on COVID-19 vaccines. And for those of you who don't know, SAGE stands for the Strategic Advisory Group of Experts. As per always, we are live streaming this webinar to YouTube, so we will be able to direct you to the recording there post-event. And if you have any questions that you'd like Annelies to answer after her presentation, please do put them into the Q&A function on Zoom, and we will try to see how many we can get to at the end of the session. We also, for those who are joining us on Zoom, we have interpretation into French. So should you wish to listen in French, please do so. So thank you very much, Annelies, for joining us. I'm going to hand to you now for your presentation. You're on mute, Annelies, so I'm just going to unmute you.
So thank you, Sarah, for inviting me today. Booster doses are indeed currently a hot topic, intensely debated by governments, by regulatory authorities, the scientific community, and organizations like WHO. So here you see the number of countries that have already introduced booster doses. At least 15 countries have started administering booster doses, and 20 million booster doses have been administered globally, with Turkey, Israel, and Chile being the leading countries. And 20 million doses are out of a total here of 5.7 billion doses, so about only 0.3%. So today I will discuss with you and share what is really the definition of a booster. What is the rationale? Why do we may want to think of a booster? And the whole booster discussion in the context of the global vaccine shortage and inequity. Then discuss what is the evidence that is required before anyone can even think of recommending boosters, the evidence that we already have, and then some of the next steps. So, start with the definition. A primary series versus booster. What is the difference? So, a primary series, and just give me a second, of a booster is to achieve an initial protective immune response in the target population for a defined period, and is often measured as a seroprotection rate, and you like to see more than 95%. So that's a primary series that targets a good immunity. The booster dose is a subsequent dose after a primary series of a vaccine administered when the initial sufficient immune response to a primary vaccine series has likely waned in your population below a protective immune response upon subsequent infection. So a booster dose is given really when your initial response, primary dose was good, and now you see waning. Typically, a booster dose elicits an immune response that increases faster, reaches higher absolute titers, and results in higher avidity antibodies and remains more durable, e.g. the subsequent decay is slower than that of the primary series. So there are two distinct potential uses for an additional vaccine dose. And I'm now using the word additional because although most vaccines have a 2-dose regimen, for Johnson it is a single dose. So I'm now calling there's an additional dose. So there are two uses. So the additional dose after initial primary vaccine series is an administration of an additional vaccine when the initial immune response following a primary vaccine series is likely to be insufficient. A booster dose is a dose administered when the initial sufficient immune response to a primary vaccine series is likely to have waned over time. And so this is now all about that the need and timing of a COVID-19 booster has not been established. And we will now talk about all the thought processes to this end. Still a little bit back to the immunology. So neutralizing antibodies seem to correlate with protection from symptomatic SARS-CoV-2 infection. Let me draw your attention now to the figure on the right. The x-axis is the probability of infection. The gray line here is the placebo line. So the unvaccinated people here, as you see, in this gray line, have a high incidence of infection. The green lines are here vaccinated person. Those with a high titer, so those with high titers of binding antibodies to spike protein have a very high protection, so very low incidence, and you see hardly any breakthrough infections. This is the black dotted line. Those with moderate or low binding antibodies still have good protection compared to the gray line, but slightly less so compared to those with high antibody titers. So highlighting again that neutralizing antibodies seem to correlate with protection from symptomatic SARS-CoV-2 infection, especially also with mild infections. Data that we have suggest that antibodies against SARS-CoV-2 persist for at least 6 months after vaccination, but we've also seen that neutralizing capacity is lower with regards to certain variants of concern, particularly the Beta variants from South Africa, and also we've seen that now for the Delta variant. Important to state again, and it's important for everyone to know, vaccines, all our current COVID-19 vaccines, do not provide sterilizing immunity. Hence, breakthrough infections are expected regardless of any concern about waning. Right? So if you have an efficacy of 95%, 5% will still have breakthrough infections. Waning of neutralizing antibodies, however, have been reported, and this is now the subject of our meeting here. That said, at present, it is still unknown what level of neutralizing antibodies or other immune markers are associated with the vaccine's protection. And we have to differ between protection against infection, that includes mild or asymptomatic, versus severe disease, and also, for example, impact on transmission. It also appears that cellular immunity is associated with protection against severe disease. So in a nutshell, really, current COVID-19 vaccines prevent severe disease. This is the good news. And vaccines have reported sustained effectiveness against severe COVID for after 6 months. While we do see an increasing number of breakthrough infections, the vast majority of these breakthrough infections are mild, clearly less severe than those seen in unvaccinated people. So what we are currently experiencing is increasingly an epidemic of the unvaccinated, while we see occasionally breakthrough infections in the vaccinated. So what is the rationale for a booster? The rationale is threefold. One, its decline over time in the vaccine performance after primary series. And this decline in performance may vary by clinical endpoints. And here I'm talking again that we have to differ between mild, severe disease and deaths. A second reason for a booster could be an insufficient response to the primary series. So people who never really fully triggered a sufficient immune response. This is different to the first, where you had initially a good response, and then you decline. For example, here, the immune compromised, or maybe also the very old. And here we prefer to use the additional dose rather than a booster dose. And the third reason is variants have evolved to a degree that protection by original vaccines may become inadequate. And a variant may then require a booster dose. I say may, right? May require then a booster dose because maybe you need higher antibody levels with a broader protection than for the original strain. Or we need a modified, a variant-adapted vaccine, and then it's almost like a re-immunizing of vaccinated individuals. Of importance, and again, this is the most important, currently our outcome of interest remains severe disease and hospitalization, as reducing mortality and protecting healthcare systems is our priority. And I think it's also very important to know there will not be an answer of all, not everything fits all. The need for a booster may differ by vaccine product, may differ by epidemiological setting or age groups or risk groups like the immune compromised versus all, and other factors. So we need a very nuanced approach to boosters. So what is the current global context? As we're discussing the issue of doses, additional doses, obviously also in the context of the global vaccine rollout and limited vaccine supply. 5.9 billion, so 5,900 million doses of COVID-19 vaccine have been administered globally. This is an incredible public health victory, unprecedented speed and scale of rollout. That said, 54 countries still remain below 10% coverage. So although we have high success and we have shipped, COVAX has shipped huge numbers to 141 participants, there is an inequitable distribution of vaccine coverage with 3 countries that have not even started a vaccination program and 54 countries still remain below the 10% coverage. And in this context, you must understand Dr. Tedros's call. His call was for a pause to use booster vaccinations, mainly for equity reasons. High first dose coverage globally, so if you achieve a high first dose coverage globally, clearly leads to a higher public health impact compared to just adding a third dose before high first dose coverage is achieved. So the emphasis currently, the public health imperative for us, for the world, remains on first increase your first dose coverage. So that's why WHO is calling for a moratorium on boosters until at least the end of September, which now is to enable at least 10% of the population of every country to be vaccinated. So what are the potential downsides of using a booster dose for all at this time of the pandemic? First of all, we have not really come to a consensus as a global community to defining or determining a threshold for true waning in VE that would trigger the need for a booster. And there may be different opinions and countries may have different objectives. For some, a minor decline, for others, a major decline would trigger it. So we need to come to consensus. But really, we should not set a poor precedent to boost every 6 months just because of some mild waning in hospitalization rates. If boosters that can have immune-mediated side effects, we also need to consider the safety. So we need to have good data on safety. If we roll out boosters too widely, too soon, it may hamper our vaccine acceptance in the future. And these considerations are from a Lancet paper recently published by the R&D blueprint at WHO, that's here on the right corner. And then higher income countries' pursuit of booster strategies further affects vaccine equity as we said, at a time when low and middle income countries have not yet administered the first dose to their priority groups. And so booster strategies may limit already limited volumes for dose sharing with other countries, and the demand for specific vaccines may increase significantly. And once one country starts implementing a booster dose, it will influence the policy decision of other countries. So we must get it right. So we have now talked about the definition of a booster, the rationale for a booster, the boosters in the context of global vaccine shortage and inequity. And now let's discuss the evidence that is required to really make policy recommendations for boosters. And the evidence must come from various sources, from RCTs, post-introduction settings, but should also be stratified by risk groups, by variants, and products, or any combination thereof. The evidence is twofold. One is assessing the need for a booster dose. So really come to a consensus, do we really need a booster dose? And second is assessing the performance of a booster dose. So for assessing the need for a booster dose, we will need and we have been looking at immunological assessments over time of post-vaccine antibodies and cellular responses. The RCTs that were the basis of the phase 3 trials, some of them were followed up for vaccine performance over time by disease and infection outcomes and by variants. However, most of the RCTs were unblinded. I will share that later with you. So very importantly, we now increasingly rely on post-introduction observational VE studies, so vaccine effectiveness studies. In next slides, I will use the word VE for vaccine effectiveness, that really show the real-world experience to evaluate the durability of vaccine performance over time, by disease and infection outcomes, and by variant. Second, do the booster doses perform? What do we have in terms of safety, immunogenicity, and disease outcomes? We will need observational studies in addition to RCTs. What is the impact on safety of booster programs? We also need to discuss whether we should go for homologous or heterologous boosters, and very importantly, determine what is the optimal timing for booster doses. And the optimal timing is likely to differ between vaccine platforms and vaccine products. So why is it so different? So we, the world, we've been looking at an evolving literature on vaccine effectiveness studies that have been conducted post-introduction. So post emergency use listing. So why is it so difficult? Well, the phase 3 RCTs, which is the most rigorous approach, were unblinded at the time of EUL, so emergency use listing, for ethical reasons, so that we could offer the vaccine also to the controls. Hence, we lost our control groups. Therefore, although some of the RCTs, they were able to still continue until the time of unblinding, and some changed to crossover studies, we do have data from RCTs, but they are relatively limited in terms of duration of vaccine efficacy beyond the phase 3 trial observation time. Hence, we need to rely on post-introduction observational studies, which all have some type of confounding and risk of bias. So what is the risk of bias? First of all, since the introduction, new variants have emerged. Because of varying epidemiology and varying extent of the rigor of public health and social measures, we have also changing incidence over time. VE estimates depend on the appropriate controls. Now, the high vaccine coverage rates that we now have in some countries make it now increasingly difficult with an increasingly smaller cohort of unvaccinated so-called controls. Controls now also increasingly get infected naturally, and therefore your effect size of vaccine effectiveness estimates will decrease over time. Then also remember, in most countries, if not all, the people that were vaccinated first were the older people. And then we move to the younger. But earlier cohorts are therefore different they are more vulnerable populations, older populations. They may have a more rapid waning. So it's very difficult to really compare with all these highly different cohorts. That said, with all the biases, nevertheless, post-introduction VE studies are crucial and probably our really only current available tool in understanding VE over time. Whilst we acknowledge some potential bias, with some careful studying, they will inform and help us with our policy decisions. To this end, WHO has published how to evaluate COVID-19 vaccine effectiveness, because most of them use an observational study design and how to interpret this data, and I highly recommend that you read this. So now let's move to the next. What evidence do we have? Do boosters work? Here, still some clinical trial data that we have from the original trial data. So Pfizer-BioNTech has some data, and FDA has just approved the dose, third dose for ICP. VRBPAC, that's the advisory group to FDA, met, and they discussed, they decided against the use of a booster for all, but were very in favor for using it for the older age groups and for health workers and possibly teachers. Moderna has ongoing studies with a 5 to 50 microgram and 100 microgram booster dose, and where we have not yet reviewed the 100 microgram dose study. ChAdOx has good data, and it looks like their maintenance of their persistence of high protection is quite long. Janssen, just early this week, in fact, just yesterday, we listened to their update but have not done a full review because we just received it yesterday. But it looks like there's an increased efficacy after the second dose. For Sinovac, they did a booster study at 8 months after the second dose, but we have not seen any regulatory approvals. For Sinopharm, we have very little data. Bharat is another inactivated vaccine where they're also doing a booster study, a study that is still ongoing, and we don't know the results. So you see, this is a rapidly evolving group work. So now there are an incredibly evolving amount of data on post-introduction experience. And we review those data almost on a weekly basis. There are various committees looking at this data. So in the next slides, I've only selected a few data that gives you impression what is happening. So first, the mRNA vaccines. Here we will see that that vaccine effectiveness against infection is relatively high for the first few months after fully vaccinated people. Then there is a trend of a decline as Delta circulation increased. By mid-July, Delta was 94%, and these are studies mainly from Israel, but also from other countries. So here you don't know whether it's waning effectiveness or is it now due to the Delta variant. The next slide shows the vaccine effectiveness against hospitalization. The slide reemphasizes vaccine effectiveness against hospitalization, and hospitalization is a proxy for severity of the disease. It remains, so sorry. It remains very high, and as you see, that it also persists for a long time, except maybe for the Puranic study where you see a decline. And remember, this is also in the context of variants. So this is the good message, the key message. The vaccine effectiveness against hospitalization is maintained, and with only a minimal trend in a decline, whilst the decline for the number of breakthrough for mild infections increases. Very important is maybe also to look at the question whether VE differs in subpopulation. And the most important here is, of course, does it differ by age? Could it decline faster in older age groups? This study here from Israel examines this question. It is a retrospective study where the authors stratified by having had the vaccine more or less than 146 days ago. So this is the vaccine estimates since time of vaccination, stratified by more or less than 146 days. In red, you see the vaccine effectiveness for those less than 146 days, and in green for more than 146 days since vaccination. And you see that VE is lower for those vaccinated more than 146 days ago, suggesting some waning. Then the authors stratified by age for those persons who had their vaccine more than 146 days ago. And you see here that indeed older age groups seem to have a higher risk, a higher adjusted odds ratio for getting infected compared to the younger. So here we're now looking at a particular subpopulation, that's the healthcare workers. This is a study from the US, and it only really looks at mild infections, no severe disease, definitely no deaths was observed in this cohort. These health workers were vaccinated prior to March, and the VE in March was very high. It's here as 93.9%. The attack rate, I'm not so sure whether you can see my pointer, but the attack rate was only 0.21 per 1,000 vaccinated health workers, compared to 3.4 in unvaccinated health workers. As that is translated into a VE of 93.9%. Over time, interestingly, the attack rate increases. And it's more importantly to look at the attack rate in the unvaccinated persons. It increased to 16.4 per 1,000, indicating that there was more transmission of the disease in the community, probably due to relaxation of public health and social measures like mask wearing and social distancing. But it also increased a bit in the fully vaccinated person, showing again that fully vaccinated persons are protected and healthcare workers need to be vaccinated. But you nevertheless see now an increase of breakthrough infections, translating this into a VE of 65.5%. Again, this is mild disease only. So now let's look at the AstraZeneca vaccine. The UK, here's a study from the UK where the AstraZeneca vaccine, that's a ChAdOx vaccine, was compared with the Pfizer vaccine. What they did was they did a household longitudinal survey amongst 18 to 64 years old. Delta was the most common virus variant during this study period. They found that the VE of the Pfizer, which is BNT162b2, against infection, that means mild infection, was reduced by 22% for every 30 days from the second vaccination. So the more you move out, there is a waning against the Pfizer. Interestingly, for ChAdOx, which is the AstraZeneca vaccine, they had a better persistence, and it was only reduced by 7% every 30 days. Now, we have meanwhile learned that a longer interdose interval, a longer interval between the two doses, improves immunogenicity. And some have asked, maybe that's the reason why AstraZeneca is doing better, because here the interval in the UK was about 12 weeks. But the difference in waning was independent for the interdose interval. Now let's move to inactivated vaccines, Sinovac and Sinopharm. Inactivated vaccines are used by many countries around the world. There are not many post-introduction observational studies for the inactivated vaccines more so though for CoronaVac, Sinovac, compared to the Sinopharm product. The first study presented here by Jara is from Chile. Chile was one of the first countries to use CoronaVac widely and probably have the most robust data. And they really have very good data here. They did a large national cohort study with more than 10 million people for all age groups. And they found that VE against symptomatic disease was 66%. And they found very good protection against hospitalizations and against ICU admissions and death. And these results are consistent with the phase 3 results. This is very encouraging results. Although the efficacy against mild disease is lower, the efficacy against severe disease is high also for the inactivated vaccines. They found overall persistence, but in the last month or so, they found some decline, and they will update us again. The other study is a study by Ranzani from Sao Paulo. They used a test negative design. Test negative design is a very robust design for post-introduction observational studies, probably the best design that we have that minimizes certain biases. Here, they only looked at the very old, defined as 70 years and above. And you see that here, your VE results are quite low, definitely lower than what we saw in the phase 3 results for the younger age group up to age 60. So it could mean that for inactivated vaccines, we need to strengthen, we need to optimize the primary series to make sure that older people who are our priority group are well protected. Brazil had another cohort of 75 million and also found 53% effectiveness against symptomatic disease and a higher against hospitalization and death, and with reduced vaccine effectiveness in those aged 80 and above. And here is the immunogenicity study done by the company itself, done by Sinovac. And as you can see here, after 2 doses, you have a very high 97% seroprotection rate. That is what we wanted, but it drops rapidly down to only 17.8% by about 6 months. And then when you give a booster, it's highly boosterable to 100%. Suggesting that maybe indeed for the inactivated vaccines, a 3rd dose is needed not as a booster, but to optimize your primary series. We've now talked mainly, shown you population-based studies. Now let's look into target groups where maybe a booster dose may be justified. A 3rd dose should be prioritized for those who are vulnerable. That means those most at risk, that could be those with immune suppression or those of older age, where we also know there is immunosenescence. That means there's also a lower immunity in older people. There may be a poor primary response to vaccination, and we've seen that for the immune compromised. They may just not respond sufficiently to 2 doses. For example, in a trial with organ transplant recipients, only 4% of people generated antibodies after 1 dose, increasing to 40% after 2 doses, but then it improved with the 3 doses to 68%. 68% is also still not optimal, and we may need to live with the fact that these vaccines have a lower vaccine effectiveness in immunocompromised people, underlying the need to vaccinate the general population well so they can indirectly protect the immune compromised. So emerging data shows that immune compromised people should receive a 3rd dose if they did not respond sufficiently to their initial doses, or if they are no longer producing antibodies. And such groups will be exempt from the booster moratorium. So this is the policy work that we at SAGE, at WHO, are still doing. We continue to review the data from all these post-introduction vaccine effectiveness studies, national cohort studies, test negative design, etc., They report to us, and we try to determine duration of protection and whether there really is an increase in breakthrough disease with a specific lens on looking whether there's waning against severe disease and deaths. It's very important that all of us communicate correctly. We will see breakthrough infections because the vaccines are not 100% effective, right? So we will see breakthrough regardless of waning. And in fact, the more people are vaccinated, the more, by definition, we'll also see breakthrough infections in vaccinated. We will need to better review additional doses in the light of immune suppression. We may need to adjust primary immunization doses for certain populations, maybe also the older persons, especially for the inactivated vaccines. We need to look at the full body of data, including immunological data, and we need to do mathematical modeling to optimize our limited vaccines that we have. In fact, we are planning a discussion on booster doses during an extraordinary SAGE meeting in November. In conclusion, our WHO and I think the world's primary objective remains focused on preventing hospitalization and deaths globally. So our strategies must align to preventing hospitalizations and deaths globally. Increasing first dose coverage globally will clearly have a higher public health impact compared to increasing third dose coverage in a small number of countries. Robust evidence on waning VE against severe hospitalizations, severe disease, hospitalization, and deaths is still lacking. Current data really are encouraging that VE against severe disease remains high, while we indeed note that we see now a decreased VE against mild breakthrough infections. WHO acknowledges the need for ongoing evaluations of VE over time. We propose a moratorium until we have more data on public health need for a third dose and on booster dose performances. But whilst we propose a moratorium, we do acknowledge that special subpopulations like the immune compromised will require special attention and may need a third booster now. This is the end of my talk. If you want to read in more detail, we have published an interim statement on COVID-19 vaccine booster doses, explaining what I explained to you, the rationale, factors to be considered, the data needs for policy, our current perspective. And thank you so much for your attention, and back to Sarah.
Thank you so much, Annelies, for the presentation. Very difficult to balance all the technical evidence along with the policy and ethical considerations. So thank you for taking that on and presenting so clearly today. We have quite a few questions that have come through, some very technical, which we will get to, but as a start, perhaps, there have been a couple of questions about the mixing of doses of vaccine from different types of vaccines. What is WHO's position on the mixing of doses as it pertains to not just primary and secondary doses, but also to the booster doses? Over to you.
Thank you. Well, there's a lot of rationale for using heterologous boosters, and we're looking at all the evidence. Several studies are being conducted with various combinations, AstraZeneca and Pfizer and AstraZeneca, inactivated and this. So we're looking at all the evidence, and the evidence we've seen so far is very encouraging. However, it's more than just immunogenicity. We also need to look at safety. So we should not really rush into heterologous schedules as yet. We still prefer the homologous, but have an open mind to heterologous priming or heterologous boosting as more data evolve.
Thanks very much, Annelies. There was a question pertaining to the data from Sinopharm. Why is there so little data from Sinopharm? You mentioned that there weren't many post-introduction studies, but is there a reason for this?
We would really like to see more studies coming from Sinopharm, and it's really a call for Sinopharm to share more data, but also to fund to conduct more observational studies. Various countries are using Sinopharm, and some of those have started evaluating post-introduction effectiveness, and some data will be coming, but for the current point in time, we do not have as much data for Sinopharm as we have for other vaccines.
Thanks, Annelies. So in your last slide, when you were looking at the conclusions, one of the statements that you made was that the impact of increasing vaccine coverage, I will read it because I'll probably say it incorrectly. Yeah, increasing first dose coverage globally will have a higher public health impact. One of the questions actually was related to this and said, are there any studies ongoing, perhaps using modeling techniques that compare the impact of starting booster doses within certain subgroups versus using the vaccines to increase coverage, primary dose coverage among the unvaccinated?
So indeed, these are mathematical models that clearly inform that your public health impact, it means your reduction, the number of deaths averted is much higher if we achieve higher first dose coverage. And that is because, as we've seen, the third dose only has an incremental, a minor improvement, right? Whilst a first dose can bring you from 0 protection now to an 85% protection, for example, with the mRNA vaccines. So clearly, from a modeling point of view, get as many first doses as possible, and fast and rapid and equitable to all countries. The rationale for the immune compromise is not a public health rationale. The immune compromised people it's only a small number in the overall global health, compared to the global population size, and there it's an individual risk that we now try to counter. But from a public global point of view, save your third doses clearly until you really have good coverage of all your priority groups first.
Thanks very much. So there was a question that came through. Before we can confirm the need for booster doses, we have to have consensus regarding either the threshold for the correlation of protection or the threshold for vaccine effectiveness, or is it both? And then a follow-up question to that was, to what extent could quantitative IgG assays be helpful as a correlate of protection? Bit of a technical one there.
So although we know that higher titers are correlated with better protection, especially against mild disease, mild infections, we do not have an absolute threshold. So we don't have a firm correlate of protection. Therefore, the biggest data need so we need to be informed really by any data that would support that there is a clear decline in vaccine effectiveness. We also need to remember, for all vaccines, the antibody titers always decline. And just declining antibodies in themselves is not a reason to give a booster. We know it for hepatitis B, we know it for various other vaccines. So clearly we need to triangulate data. So we need the full package. That's the modeling, it's the immunogenicity, the antibody titers, the full range, but really the most important data set is indeed the any evidence that there's clinically a reduction in protection against severe disease and death.
Thanks, Annelies. I know you did mention the time between doses, but somebody has asked what time period could be considered as an interval between the primary vaccination, full 2 doses or 1 dose as required, and the booster.
So it may differ by vaccine product, and we also need to look compare between optimize your primary vaccine series versus a true booster dose. So, for example, inactivated vaccines, where we currently use 2 doses, may work better in a 3-dose schedule as a primary schedule. And then calling the 3rd dose just as part of the primary, like a 2+1 primary series rather than a booster. I think anything by definition that is given beyond six months is usually considered a booster dose. The optimal timing will be a balance and a trade-off between, you know, a clear waning of vaccine effectiveness and based on modeling your optimal your best use of limited vaccine supplies. So there won't be a straight answer, and the answer may also change over time because vaccine supply constraints will decrease. We'll have more vaccines in the very near future. From 2022, I think we will have quite good vaccine supplies. So the answer may differ, but in general, a booster would be more than 6 months given after the last dose, and optimizing your primary series would be usually within the 6 months or at 6 months.
Great, thank you. How do you define a poor response to a vaccine?
So there are different measurements. One is your seroprotection rate, your seroconversion, your neutralizing antibodies, your binding antibodies. So I think you bring a whole range of data to really determine a poor response. But most importantly, in addition to the immunological, is really the clinical protection. What is your efficacy in your randomized controlled trials? What's your primary efficacy? Is there really a waning over time in clinical protection? And that is the most important measure.
Thanks, Annelies. We had an EPI-WIN webinar not that long ago on the monitoring of adverse events after vaccination. Presumably the same is happening for the administration of booster doses. Can you speak a little bit about that, where that information is and who's doing that monitoring?
So it is important that countries that have gone ahead with a booster dose implement safety monitoring for vaccine effectiveness to really document whether a 3rd dose really translates into improved vaccine effectiveness. So a call for all countries to have already introduced a booster dose. Then, of course, we need to do prospective studies, maybe ideally even RCTs. We need to benefit from the RCTs that the companies have been doing. So again, we can call upon various sources of data to inform policy decisions. But just to highlight again, the safety issue, for example, for heterologous boosting, we need sufficient observation time for safety monitoring, and we need also relatively large numbers, because some of the side effects, some of the safety concerns only become apparent if you have large sample sizes. So partially we will learn from the country's experiences, partially we will learn from rigorous conducted prospective studies.
Great, thanks, Annelies. So there is a question that's come through asking, is there any evidence about the impact on immunity of a full primary vaccination regime and then subsequent mild breakthrough infection?
So we have evidence on that a 3rd dose for all the vaccines that we have looked at, so it's the mRNA vaccines, it's also inactivated vaccines, that they are boosterable. So that there's a rapid increase in neutralizing antibodies, and that which should be higher even than the peak titer after the 2nd dose. That's the definition of boosterability: is the speed of the rise of the antibody titers and the durability then as the booster. So we do have results from that. Specifically to the question whether we can so whether we can relate the booster doses with breakthrough, no, I have not seen any data. But prior to the boosters, we do know that that lower neutralizing antibody titers are correlated with a higher risk of breakthrough infections. And here is mainly mild infections.
Thanks, Annelies. We have a number of comments that have come through in the chat and the Q&A saying that really emphasizing what you said about the moral obligation for us to pursue in coverage of primary doses everywhere rather than advocating for booster doses on a widespread scale. So I think there are many listening today who support and welcome that. We'll try and answer a few more questions. We're heading towards the hour, and I understand everybody needs to rush off to their next Zoom call. So there's one that's come through from Steve. Public Health England data from last week shows that the rates, not just numbers of infections, are higher in the 40 to 79-year-old age groups who are vaccinated than the unvaccinated. Could you talk about the impact of risk compensation, which might be influencing this and some of the breakthrough infections we are seeing in other countries?
So just to make so first of all, I'm not sure which data he refers to, but just to make sure everyone understands the risk of breakthrough infections is far lower in vaccinated compared to in unvaccinated. However, if you have an increasing proportion of vaccinated in your country versus unvaccinated, your absolute number of breakthrough infections will increase in the vaccinated compared to the unvaccinated. This is a mathematical paradox, and that's very difficult to communicate. Many people do not understand. So therefore, if you want to simplify my message, the message is clearly the risk of breakthrough infection is 20 to 30-fold lower in vaccinated persons versus unvaccinated. But the risk of severe disease is almost zero, not totally zero, but very low in the vaccinated versus the unvaccinated. But indeed, in very old age groups that already have comorbidities and are at higher risk per se of dying, you will definitely see more breakthrough and maybe also then more severe disease in vaccinated persons there. But please go home with the message. Severe disease is very well maintained. We have seen no waning, hardly any waning in the vaccinated, and even your breakthrough infections remain much lower as a risk in the vaccinated versus the unvaccinated.
Wonderful, thank you, Annelies. And I think we're going to end on that message so that it stays with people as we go about the rest of our days. I want to thank you once again for coming on the webinar and presenting and answering so many questions. I want to thank the audience who've come today, listened and asked the questions. As a small reiteration, we will be sharing the slides with everybody who has registered for this webinar after the event, so look out for those. And as usual, the recording can be found on the EPI-WIN YouTube channel for those who missed the start or want to share it on. So thank you all to everybody, and thank you very much, Annelies, for coming and being here today. Take care, everybody, and we look forward to seeing you in the near future. Bye-bye.